Good afternoon, everyone. Today we are going to discuss on leprosy. It is a very important topic. Leprosy is also called Hansen's disease, and leprosy is defined as a chronic granulomatous disease which is caused by Mycobacterium leprae, and it mainly affects the peripheral nervous system, skin, and certain other tissues. Transmission is by respiratory tract. The incubation period is usually 3 to 5 years. The duration can be taken as 2 to 7 years. Etiology, we have already said, it is caused by Mycobacterium leprae bacilli, and it is acid-fast, alcohol-fast, obligate intracellular Mycobacterium. Another acid-fast bacteria, it's Mycobacterium tuberculosis, which causes tuberculosis. And these Mycobacterium leprae bacilli mainly reside within macrophages, but can also reside within Schwann cells and endothelial cells of blood vessels. It is stained by Gill-Nelson method. It is not stained by Gram stain. It is stained by Gill-Nelson method after slit skin smears. And what you see after Gill-Nelson method of staining, there are pink rod-shaped bacilli, which either lie singly or in clumps or in compact masses within macrophages, which are called globi. These bacilli, Mycobacterium leprae bacilli, do not grow in culture media, but they can be grown in footpads of mice and 9-banded armadillo. In this picture, you can see these are all pink rod-shaped bacilli. These are single, these are in clumps, and these adhered clumps of Mycobacterium leprae are called globi. Mycobacterium leprae is non-toxic to human tissues. However, clinical feature is produced by host immune response against the bacilli and the accumulation of bacilli or infiltration of bacilli, mainly in the nerves and skin. There are two types of classification. For the classification of leprosy, one is WHO classification, another is Ridley-Jopling classification. According to WHO classification, the leprosy is either paucibacillary leprosy or multibacillary leprosy. This classification is important for the treatment purpose because there is, for the paucibacillary leprosy, the regimen is different, and for ambileprosy, the regimen is different. In paucibacillary leprosy, the skin lesions are less than or equals to 5. In multibacillary leprosy, skin lesion is more than 5. In paucibacillary leprosy, there is no nerve involvement or single nerve involvement. In multibacillary leprosy, the nerve involved is more than 1. And the paucibacillary leprosy is acid-fast bacilli negative, and the multibacillary leprosy is acid-fast bacilli positive. That means after the taking smear and doing ZN staining, we do not see any bacilli in paucibacillary leprosy, but it is positive in case of multibacillary leprosy. And in Ridley-Jopling classification, it can be classified as tuberculoid leprosy, borderline-tuberculoid leprosy, borderline leprosy, borderline lepromatous leprosy, and lepromatous leprosy. These are 5 classification of Ridley-Jopling classification. And this graph shows the relationship of the pool of leprosy with that of host immunity. As you can see, in tuberculoid leprosy, the cell-mediated immunity is good, and the cell-mediated immunity decreases as the pool increases to lepromatous leprosy. So in lepromatous leprosy, cell-mediated immunity is very poor. And in tuberculoid leprosy, bacterial load is very less. However, the bacterial load keeps on increasing as the pool increases from tuberculoid to lepromatous leprosy. Now the clinical features. The most important thing that you should remember are the Cardinal signs of leprosy. There are 3 cardinal signs of leprosy that you should know. First one is hypopigmented or erythematous patches with definite loss of sensation. There are skin lesions that are hypopigmented or erythematous with definite loss of sensation. Hypoanesthetic patches. And second one, there is thickened peripheral nerve trunks at the site of predilection. And third, acid fast bacilli is seen in slit skin smell. These are the 3 important cardinal signs of leprosy. There are other signs also which suggest leprosy. Right? These are the skin patches, which may be single or multiple. Diffuse infiltration of the skin. The skin patches are usually hypoaesthetic. Right? Means there is decreased sensation over the skin patch, but however, the sensation, loss of sensation is less in lepromatous form. There can be diffuse infiltration of the skin. Skin is red, thickened, shiny skin if there is diffuse infiltration. There can be skin nodules. There can be loss of sensation in the hands or feet. There can be ulcer in hands and feet. There can be paralysis of the muscle due to neuritis. Patient may present with claw hand, foot drop, or wrist drop. These are due to paralysis of nerves. There can be paresthesia, that is tingling and numbness in hand and feet. And there can be pain in the nerve trunk. Other signs are loss of eyebrows, which are called madrosis, collapse of the nasal bridge. There can be bilateral pedal edema also. There can be redness and excessive watering from eyes and bleeding from the nose also. All these features are signs of lepromatous leprosy, these 5 features. There can be dryness of skin, there can be earlobe infiltration, there can be bilateral gynecomastia. Now the clinical features varies in different pool of the leprosy. In tuberculoid leprosy, the lesion is usually single, but maybe 2 or 3. And the lesion is erythematous plaque with raised and well-defined edges, which have a tendency to central flattening. I will show you a picture. Less commonly, the lesion of tuberculoid leprosy can be macule. Hair growth is less or absent over the lesion, and sensation is impaired. Touch, temperature, and pain sensation can be impaired. Is definitely impaired in tuberculoid leprosy. There is thickened nerve, which is palpable in the vicinity of the tuberculoid lesion, and other neural symptoms can also be seen like pain, loss of sensation, tingling, muscle weakness, or paralysis. You can see there is well-defined erythematous plaque with well-defined raised margin, which has a tendency to central flattening. This is the lesion of tuberculoid leprosy. Another, borderline tuberculoid leprosy. Skin lesions can be macules or plaques. It resembles tuberculoid leprosy in appearance and sensory loss, but the lesions are not so large. In tuberculoid leprosy, the lesions can be up to 10 centimeters, but in borderline tuberculoid leprosy, the lesions are not so large, but more numerous, more than 1, 2, 3. Sometimes up to 10 lesions are present in borderline tuberculoid leprosy. And their surface is dry and outer edges are less clear-cut than that of tuberculoid leprosy. As you can see, there is well-defined erythematous plaque, and the outer edges are less clear than that of tuberculoid leprosy, as we have already seen. Another is borderline leprosy, in which there are few to multiple annular plaques and papules with sharply marginated interior and poorly defined outer edge. This type of lesion are called punched out lesion because the inner margin is well defined and the outer margin is ill defined. It is also called inverted saucer shaped lesion. It appears like inverted saucer. And there can be islands of normal skin within the plaque, giving rise to cheese appearance, cheese-like appearance. And in borderline leprosy, there are multiple asymmetric lesions with sensory impairment. You can see There is well-defined inner margin and ill-defined outer margin. It is called punched out lesion, or also inverted saucer-shaped lesion. In borderline lepromatous leprosy, the lesions are numerous and may appear like a lepromatous leprosy. But the lesions are not truly bilaterally symmetrical like that of lepromatous leprosy. And there are no other lepromatous features like madrosis, keratitis, saddle nose deformity, or leonine faces. This is the picture showing the lesions of borderline lepromatous lesion. You can see hypopigmented macules and plaques, but these are not bilaterally symmetrical. There are multiple but not bilaterally symmetrical. In lepromatous leprosy, there can be multiple macules, papules, nodules, which are distributed bilateral and they are symmetrical. The lesions are usually ill-defined and shiny, and sensation to touch, pinprick, or temperature is usually unimpaired. Right? The sensation is mostly gone in tuberculoid leprosy, but as it comes to the poor lepromatous leprosy, the sensation is usually intact. And as the disease advances, there can be diffuse thickening of facial skin, nose, and ears. And the longest peripheral sensory nerves fibers are first affected. So there is numbness and anesthesia first over the dorsum of hands and feet, which later progresses to extensor surface of arms and legs. There can be nasal symptoms like stuffiness, discharge, epistaxis, and edema of legs and ankles. And if the patient remains untreated, the lines of forehead become deeper as the skin thickens, and these give rise to the appearance leonine faces, thickening of the skin with deeper furrowings. And eyebrows and eyelashes become thin or lost, which is called madrosis, and earlobes are also thickened due to infiltration. There is saddle nose deformity, we have already said. There can be lag of thalamus due to damage to the facial nerve. There can be leprous deposits in the eyes, which cause keratitis, iridocyclitis, and iris atrophy. In males, there can be testicular damage, which causes sterility and gynecomastia. In this picture, you can see there is diffuse infiltration over forehead, eyebrow, cheeks, nose, lips, earlobes, and there is thickening of skin with furrowing. There is saddle nose deformity. There is loss of eyebrows, which is called madrosis. And these all give the appearance of lion-like face, which is called leonine facing, which is seen in lepromatous leprosy. This is another picture showing diffuse infiltration in case of, as you can see, there is infiltrated nodules in case of lepromatous leprosy. There is one term called indeterminate leprosy, which is the early and transitory stage of leprosy. It is usually found in children, and skin lesions are maculous, hypopigmented, or faintly erythematous. And the outer edges of macules vary from ill-defined to well-defined. And slight anesthesia may be present, but it is usually absent, means the sensation is usually normal in case of indeterminate leprosy. And about 30% of this indeterminate leprosy progress to determinate type, rest resolve on themselves. There is another term called pure neural leprosy, in which there is no skin lesions, but there is involvement of peripheral nerves, but you cannot see skin lesions. It is called pure neural leprosy. Now, for the examination of leprosy patients, there must be good light to examine the leprosy patient. As you can see, faintly hypopigmented lesions over the body in case of lepromatous leprosy. And the entire skin surface from face to toe should be examined. And the sensation test which we should do are thermal, touch, and pain. For thermal test, we take 2 test tubes, one containing hot and one containing cold water. we do hot and cold sensation test. For touch test, we take wisp of cotton, and for pain sensation, we take pin. This is called pin prick sensation. And while examining the patient, you should notice number of skin lesions, size and shape of the skin lesions, margin of the skin lesion, surfaces of the skin lesion, either there is sweating, dryness or hair loss, and the distribution of skin lesions, either they are symmetrical, asymmetrical, and the cutaneous nerve involvement over or around in the vicinity of the skin lesions. These are the specific cutaneous nerve we should examine in case of the leprosy patient. First one is supraorbital, and there we can examine infraorbital also and supratrochlear also. These are the peripheral nerves. Another one is greater auricular nerves. We usually do not examine cervical nerve. Another one is radial nerve. Another one is radial cutaneous nerve, and common peroneal nerve and posterior tibial nerve. These are the most important peripheral nerve we palpate in case of leprosy patients. Now the reactions of leprosy, there are main two types of leprosy reaction, type 1 and type 2 reactions. Type 1 reactions mainly occur in borderline leprosy, either borderline-tuberculoid, borderline or borderline lepromatous leprosy. It is characterized by acute neuritis and acutely inflamed skin lesions. Okay. The previous lesions which are already present become erythematous and edematous and may desquamate and ulcerate. There can be edema of the face, hands and feet, and most type 1 reactions occur in the first 12 months after starting treatment. This is the type 1 reaction. You can see the lesions are edematous, erythematous, and these are painful. Okay. There is pain also. And type 2 reaction, which are also called erythema nodosum leprosum, occur in patients with multibacillary disease, that is lepromatous leprosy and borderline lepromatous leprosy. It manifests as painful erythematous nodule, which mainly appears on the extensor surfaces of the limb, right? Arms, legs, and face. They may ulcerate. Sometimes there can be formation of pustule also, and they usually resolve within 5 to 7 days with hyperpigmentation. These are called erythema nodosum, and the type 2 reaction is called erythema nodosum leprosum. In type 1 reaction, there is no involvement of systemic features. However, in type 2 reactions, systemic features are also seen like fever, malaise, uveitis, dactylitis, arthritis, lymphadenitis, myositis, orchitis, and peripheral lobulitis. These are the ENL lesions, erythema nodosum leprosum lesions. These are, as you palpate, erythematous, painful, evanescent nodules. Evanescent means they appear and disappear in 5 to 7 days. You can see there is ulceration also over ENL. Now the complications of leprosy. There can be deformities of hands and feet. These are mainly due to paralysis of the nerves. We have already seen the peripheral nerves that is mostly affected by the Mycobacterium leprobacilli. The most common deformities that occurs due to paralysis of peripheral nerves are cloan. It occurs due to ulnar nerve deficiency. Right? Partial cloan occurs due to ulnar nerve deficiency, and total cloan appears due to paralysis of ulnar plus median nerve paralysis. Wrist drop is due to paralysis of radial nerve. Foot drop is due to paralysis of common peroneal nerve. And trophic ulcers. These are the neuropathic ulcers that are seen over the pressure points. due to loss of sensations. In leprosy, the trophic ulcers are mostly seen over the feet. And there can be deformities of face also, as we have seen saddle nose deformity and mad noses, and deformities of eyes, mainly due to facial nerve paralysis. There can be lag of thalamus and ectropion. And other systems that are involved can be, there can be renal involvement, testicular dysfunction, and eyes. In eyes, there can be cataract, glaucoma, and stereotypoma. These other systems are involved mainly in case of lepromatous leprosy with type 2 complication, that is erythema nodosum leprosum. For the diagnosis, main diagnosis is clinical. Then after clinical diagnosis, we go for slit skin smear and skin biopsy usually. But sometimes no biopsy can also be done, like that in case of pure needle leprosy. And there is lepromin test, serology test also in available, but we do not practice these days nowadays. Now for the slit skin smear in leprosy, we take mainly 4 smears, right? 2 from the earlobes, 2 from earlobes, and 2 from skin lesion if there is skin lesion present. If there is no active lesion, we take 2, in case of male, from right arm and right buttock, and in case of female, from right arm and right thigh. And you should know how to take slit skin smear. It's mainly like you see in clinical posting. First of all, we explain the patient about the procedure and clean the site with spirit swab and pinch the area to make bloodless. There should not be blood in smear. And we cut 5 mm long and 2 mm deep cut split in the dermo-epidermal junction and scrape the bloodless tissue fluid. The tissue fluid is from dermis and we spread it in the slide. Make a smear around 6 to 8 millimeters. And after making smear, we dry at room temperature and fix the slide over flame. Heat fixing, it is called heat fixing. And we do Gill-Nielsen staining. Gill-Nielsen staining you must have read in basic science. You should do revision once. It's like you should know the Gill-Nielsen method of staining. The stains that are used, primary stain is 1% carbofuscin. For decolorization, we use either 1% acid alcohol or 5% sulfuric acid. And for counter staining, we use 1% methylene group. We first take a slide with smear and put on carbofuscin. Keep it for 15 minutes. Then wash with tap water. Then we decolorize with either 1% acid alcohol or 5% sulfuric acid solution. And again wash with tap water. Then for the counter staining, we put on 1% methylene group for 1 minute and then wash with tap water and we dry the slide, air dry. Then we see under the microscope. We have to see the bacilli under. First of all, we focus on the 10x magnification, then we see under 100x magnification. And for the, usually we see bacilli, but we have to calculate bacteriological index also for the treatment purpose. And what is bacillary index or bacteriological index? It is the estimation of the number of bacilli in the smear. And the average bacillary index is the average number of bacilli in all sites examined, which is calculated by the sum total of the bacillary index on all sites examined divided by the number of sites examined. And there is another term called morphological index. It is the estimation of solidly stained bacilli in a smear. The characteristic of allied bacilli are they are evenly stained. Both ends are round. The length is 5 times the width, and the sides are parallel. This is the bacillary index that we see in the smears, and you should know this index also. We say 1 plus bacillary index if there are 1 to 10 bacilli in 100 fields. It is 2 plus if there is 1 to 10 bacilli in 10 fields. It is 3 plus if there is 1 to 10 bacilli in average field. It is 4 plus if there are 10 to 100 bacilli in average field. It is 5 plus if there are 100 to 1000 bacilli in average field. And 6 plus if there are more than 1000 bacilli in a field. These are which are called globi. And in histopathology also, there are a few things you should know in histopathology. The histopathology of tuberculoid leprosy and lepromatous leprosy is slightly different. In tuberculoid leprosy, you see epithelioid granulomas throughout the dermis, which consist of Langenstein cell, macrophages, and lymphocytes. And there is infiltration around the peripheral nerves, pericles, and erector pylorem. In lepromatous leprosy, you see a normal epidermis and a clear zone, grain zone between epidermis and dermis. And below the grain zone, there are macrophages laden with bacilli, which are abundant pink to pale cytoplasm, which correspond to numerous intracellular organisms. And as opposed to the tuberculoid leprosy, there are no well-formed granulomas or infiltration of nerves in case of lepromatous leprosy. Now the treatment part. The principles of treatment are early detection of the patient, appropriate treatment, prevention of disabilities and rehabilitation, and treatment of reaction and reduction of the risk of nerve damage, and educate the patient to cope with existing nerve damage and treat the complication of nerve damage, as well as rehabilitate the patient socially and psychologically. This is the adult PBMDT blister pack. Right? This PBMDT blister pack is used for the treatment of paucillary bacillary. So you should know what is paucibacillary leprosy before starting. Starting paucibacillary MDT. Right? In paucibacillary MDT blister pack, this blister pack consists of the drop for 28 days. Right? We give monthly rifampicin 600 mg and dapsone 100 mg. It's a supervised dose which is given on day 1, and from day 2, the patient himself can take the medication which we give dapsone 100 mg. Right? From day 2 to 28. We'll repeat again. We'll give in the day 4 supervised dose of 600 mg rifampicin. This is 300 mg rifampicin, 300 mg rifampicin plus 100 mg dapsone. And from day 2, we have to give dapsone 100 mg daily until day 28. And the duration of treatment, you do not need to know children doses. And for the duration of paucibacillary patients, treatment is 6 months, but it can be completed within 9 months period. And this is the adult MDT blister pack, which we give for multibacillary leprosy. In day 1, supervised dose, we give rifampicin 600 mg, clofazimine 300 mg, and dapsone 100 mg. You see, this is 300 mg rifampicin, 300 mg rifampicin. This is clofazimine 100 mg, 100 mg, 100 mg. It's total of 300 mg. Rifampicin is total of 600 mg, and it is 100 mg dapsone. And from day 2, we give clofazimine 50 mg. This is clofazimine. It's red colored. It's 50 mg, and dapsone 100 mg. This is dapsone. It's 100 mg. It's also for 28 days. And we give 12 blister pack for MDT. Right? And the 12 blister pack, we usually complete in 12 months, but it may be completed within 18 months, no problem. Now for the pre-treatment evaluation, you should do the complete blood count including platelets, blood urea, creatinine, random blood sugar, urinary, LFT, including serum bilirubin, serum albumin, and if available, G6PD. Okay? We'll discuss why G6PD is needed. For this, we will first discuss the drug reactions. What are the side effects of these reactions, these drugs? First of all, rifampicin. Rifampicin, once taken, may produce red-colored urine and red-colored secretions, which is not a thing to be worried. Sometimes it may produce side effect like flu-like syndrome, hepatitis, which should be treated. And dapsone, which is important, is the main drug which causes side effect in leprosy patient. It can cause hemolysis, mainly in G6PD deficient patients. It can cause peripheral neuropathy. It can cause drug hypersensitivity syndrome, which is called DRESS. It is associated with fever, eosinophilia, and erythroderma. We'll study DRESS or drug hypersensitivity syndrome in the topic of drug reactions. And side effect of clofazimine. Clofazimine mainly causes reddish discoloration of the skin. It is seen in almost all the patients taking clofazimine. There is coppery red discoloration of the skin, which disappears once the medication is stopped. Right? And another side effect of clofazimine is xerosis, that is dryness of the skin. These are the pre-treatment evaluation that we should do before starting the treatment. And what we call completion of the treatment and cure. For the possibacillary disease, any patient who has taken 6 doses of PBMDT within 9 months is considered as cured. And for multibacillary disease, any patient who had taken 12 doses of MDMDT within 18 months is considered as cured. Post-treatment surveillance should be done once yearly for 2 years for possibacillary patients and once yearly for 5 years for multibacillary patients. And now the treatment of reactions also. We have discussed the treatment of disease, and we should do the treatment of reactions also because the reactions are also very common. In case of type 1 reaction, if the disease is mild, we can give NSAIDs also, NSAIDs only. And if it is moderate to severe, we have to give corticosteroids. The corticosteroid mainly given in reactions is prednisolone, 1 mg per kg, and we later taper the dose of prednisolone, and we usually give the prednisolone for around 12 weeks or 3 months. Okay. If prednisolone alone is not helping or high dose of prednisolone is required, we add other immunosuppressants like methotrexate, cyclosporine, azathioprine, mycophenolate mofetil. And in case of type 2 reactions also, in mild case you can give NSAIDs, and in severe case we have to give corticosteroid plus high dose. We usually use 50 mg daily clofazimine, but high doses of clofazimine in case of type 2 reaction. And there is one drug called thalidomide, which we give for type 2 reaction. Okay. Thalidomide is it's difficult to get thalidomide in the market. You have to first admit the patient and give thalidomide. This is available in only few places in Nepal. And there is one important side effect of thalidomide. You must have heard phocomelia, which is very frequently discussed side effect. Phocomelia, which is caused by thalidomide. Right? So it must not be given in women with reproductive age group. It is the teratogenic effect. And other immunosuppressions can also be given in type 2 reactions like methotrexate, cyclosporine, azathioprine, and mycophenolate mofetil. Okay. Thank you. Any questions?